Small line. What did I do? Did I mess it up? So anyway, let me just sort of sending. Okay. So this is like the list of the papers that we. Well, let me start with hi everyone. Happy Friday. So, I think everybody was on the call on Tuesday, but just a summary. And I know some of you helped with the extraction of the literature. What we did during the last week was to look at the PubMed, do like an abstract, title an abstract review, sort of like limit the publications to what we think should be good enough for full text review. 45 initially was identified as those that should be gone through evaluation, and 40 of the 45 have had the relevant codes or had some information that could tell us how the phenotype was developed within that paper. So, and we did a review last Tuesday or this Tuesday about like what has happened. So those of you who remember, the whole idea was that, okay, like there's a lot of things that we actually get here. And one of the big things is that across the 40 papers that we extracted the information, there's no one paper. There's basically that tells you what is non-small cell lung cancer, what is small cell lung cancer. It is not, and like we all know that there's no such a thing as small cell lung cancer, non-small cell lung cancer. All the phenotypes are created within a context of a purpose and to answer a study. So like I want to do economic burden, I want to look at treatment utilization, I want to look at safety of this specific treatment. And that's why like when you look at the phenotypes, these are the clean description, you see that like some of them are non-small cell lung cancer treated with radiotherapy and ICI, the other one is initiated first line of treatment with afitinib and then erlotinib, the other one goes to ALK inhibitor, so it's all over the place. And then we see the databases, and databases like are a general suspect of a good proportion. The majority of them are using a registry, and very, very specifically SEER Medicare and registry linked with claims. SEER Medicare is the winner. Most of the data, the studies are using SEER Medicare. Good reason. You can get the correct codes that can help you identify non-small cell lung cancer. But the caveat that even if you look into the SEER Medicare, you see that the codes are all over the place. Some people use certain ones and some, there are discrepancies. But then we have the other usual suspects of claims, mostly, and some EMRs that there's always a combination of ICDs plus some sort of like magic gymnastic of combining it with something else or a series of other stuff. And that's what we actually summarize here. So how did non-small cell lung cancer, small cell lung cancer was created, which vocabulary, and then the additional criteria or constraint that was used to develop that phenotype. And I showed you last Tuesday that it's like, there's no pretty much like sort of like consistency across the work, and this like these are the specific purpose, like looking at survival, economic burden. So I opened up the discussion on Tuesday, and we want to actually continue this. This is like a big thing of like, what is it that we want to phenotype here? Can we pick up one or two from this list? And to be honest, I think it's a decision for all of us. We have to come up to an agreement, and in light of the pros and cons, what is it that we want to do and what not? Aza and Anna did the whole assessment and looked at like some of these literature, especially like in terms of the similarities or not, with like, can we find the same or just similar phenotypes? Then we start with that, but I'm gonna leave it open, and that's what the color coding shows you. But I'm gonna open up the conversation, and Aza, do you want to tell yours, what you've done? And
Yeah, so just put it in the context of what we originally trying to do for Phenotype February. The reason why we got slightly stuck here, and we kind of decided to pause the last 24 hours and say, take this call today to open a discussion and see what other people, especially who's familiar with the disease, also has in mind. So the idea is about consistency in the literature. However, that that means that we have an assumption that there is a common phenotype that all these papers are addressing. So in the simple case of Alzheimer, regardless of what the study purpose is or objective to get out of observational evidence, everybody has a common factor of having a phenotype for Alzheimer. So they wanted to study something about patients with Alzheimer. In virtue of that, they had to define what that looks like. So because they all have that common factor, regardless of the study is, and it's untangled of the purpose of the study, we were able to say all these papers had the aim to define Alzheimer, regardless of why they want to do that. And we're going to look at the consistency of that, whether how they define it, what code they use, what logic they used, and so forth. In lung cancer and non-small lung cancer and small lung cancer, however, that common factor of a phenotype for the disease itself is actually never on all these papers we found, is actually never there. Lung cancer is used as an inclusion criteria in a compound phenotype where treatment most commonly is part of the phenotype itself, of course, just to satisfy the purpose of the study. But it is because what I'm coming to learn is non-small cell lung cancer is on itself is not a clinically defined idea that you could just go and try to phenotype that. It is always tangled, at least in practice.
Yeah, so from a clinical and a pathology perspective, non-small cell lung cancer is different from small cell lung cancer. Let's not mix that one from
I understand
the availability of codes to distinguish the two. The non-small cell cancer versus small cell lung cancer have different types of treatments, have different types of histology, and they are completely different diseases.
Correct, but maybe because of the presentation of observational data, which even the most granular one, including registries that has histology and pathology, the patients group that these papers address is always have an algorithm that include the treatment and of course it is specific to the purpose, as Asia said, but it's almost like you can't uncouple those two. You can't uncouple the phenotype of the disease itself from the treatment, because the treatment is used as a virtue to kind of confirm that this is the patients you're interested in, and also to address the research question. So it becomes really hard to say, well, let's just focus on non-small lung cancer and try to see the consistency across that. We could, but it will really go down into a inclusion criteria that it's used in those studies. And maybe I'll say you go back and you share the studies, because it's actually make the point. Which we could do that, or we could find, so the two options we can go is just say, you know what, regardless of the studies, they all have an inclusion criteria having the indication, having the lung cancer, and how they handle this might be different. And let's focus on assessing the consistency there, which will make our work more focused on concept set, because that's most what it is. The second idea is let's focus on a subset of like people treated with line 1 therapy, or people treated with chemotherapy, or people treated with a surgery, and address the inconsistency there. But that will make all that universe of 45 papers down to 2 papers at most, or 3 papers. But this is our idea. But then I don't people must have more ideas and how they're thinking about it.
So let me just add to that before I share that. So 2 things, right? So what Oz said is absolutely correct. And and then what Gowtham was saying is correct. You have a distinction between small cell lung cancer and non-small cell lung cancer. And if you have that data, I know some of you have, you have the pathology codes, and then you know that it's in lung, right? You have ICD-O, and you can actually say this is small cell, this is non-small cell lung cancer, right? That's what people do in SEER, like when you even like do the SEER Medicare data, like they actually get to that details. Right? That's like how I want to define a disease. Like this constellation of histology and topology identify or would make patients, like would identify patients with non-small cell lung cancer. That's great, with the caveat that like, are they doing the same thing? No. The other problem is that when you're reviewing these studies, a thing called non-small cell lung cancer is usually not so a lot of cancer studies are like cancer becomes a target cohort, is a study population. You define your exposures and outcomes, your target comparator, and you look at the patient. Sometimes cancer will become an outcome, right? So that thing, okay, like is exposure to drug X like increase the risk of say lung cancer or not, like within like a very, very long time span. That's a different thing. In the majority of the cases, we actually look at like how patients are being treated, what's the economic burden, what's the survival. Then within that context, a thing called non-small cell lung cancer is not as informative because that umbrella of non-small cell lung cancer becomes like these very, very tiny pieces of diseases or entities, like tiny diseases that each have their own characteristics. So whether it's an adenocarcinoma or squamous cell carcinoma, whether there's an ALK rearrangement or PD-L1 status is high or low, there is an EGFR mutation, and whether there's a combination of that would define a different type of patients in terms of response to treatment or characteristics. And that's why, like, we've ended up, and we see what exactly Ozzy said, like, it's a combination of all of them, right? Like, you see, like, a phenotype develop based on, like, a lot of gymnastic and put them all together. And then also we can't find, like, the two that are absolutely the same because people have different questions. And it's a little bit even hard to say that, like, why did they do that? Because, wait, there is no code. Like, I have ICD-10. I have to make a lot of assumptions, but also that's the population I want to answer. So just to put the context, and then we can take a look into the sheet and then discuss together. Okay, let me see.
Anybody who's familiar with those studies or whatever is useful for studying phenotypes in lung cancer? Anybody have ideas or have reflections or have thoughts?
So one thing that maybe we can actually start thinking about, like, so like if there's a difference between like how like I want to look into ICD-Os or ICD-10, and then that the total number of papers and the type of papers will change. But others, like I know, like there are a few folks on the call who help with the abstraction, and also I know some folks who do oncology research. Andy, oh, Gowtham, sorry, I don't see anyone.
No, go ahead, Andy. Sorry, I didn't see the hand.
So, maybe this is a stupid question, but I'm guessing that a lot of the studies that were performed were prospective trials where data was specifically collected to identify a patient population or to assess a certain outcome. And when we're going back to observational data, what we're, I presume, required to use is only data that was collected for whatever reason, not as part of a clinical trial. And therefore, the missing data that might be there if we require a certain type of pathology report or whatever phenotype that we're developing that's not based on commonly recorded codes. Is there this balance between trying to get it as specific as possible or trying to get it as close to these definitions as possible, yet not having that data regularly captured through practice of care? And maybe it's a stupid question. Maybe all this is always captured.
Actually, this is a good question, but to your point, these are all retrospective data. These are all observational studies.
Oh, they were.
So
okay.
people with data, not necessarily OHDSI, like or any like in OMAP or not, like anyone that has some data, like proven parametrics, they've developed their own algorithm, and that's what we're trying to assess. Like, can we identify a definition for non-small cell lung cancer? or a bunch, and then try to look at the heterogeneity or similarity between the two. That's why,
Okay.
like, you see the ICD-O, because these folks have SEER data, and then the TrueVen people don't. So they do different things.
Got it. Okay, so the fact that these were actually regularly captured data
Exactly.
makes it comparable. So that makes my point irrelevant, really. So, okay, thanks.
I think Samir.
I think Gowtham first. Go
Yeah.
Gowtham.
Yeah, I'll go very quickly. So just to make sure I understand the point that so far, the community asked for non-small cell lung cancer and small cell lung cancer. The community did a thorough literature search and then abstracted what was found. And I think what I'm hearing is, based on the column G, there was no one paper that talked about just non-small cell lung cancer or small cell lung cancer, but they were all like some specialized subtypes of it that were nested within a treatment for a specialized subtype of non-small
Mostly.
cell cancer, such as an advanced stage 4 disease or with a certain type of genetic mutation, and they're modeling it based on some treatment pattern. So it's a combination of treatment pattern nested with a broad diagnosis code. And that's what they have modeled. And I think what the conclusion that you're drawing is, we have many of these clinical ideas now. We don't have one clinical idea that we can go after. And no two papers have modeled the same clinical idea. So we just can't compare anymore, because there's no two papers which have modeled the exact same stage, combination of genetic mutation, something like that. Is that accurate?
Yes, and yes. And very specifically for those who are not using. So the SEER Medicares are also the same, because they also want to look into patient treatment. But very specifically, yeah, exactly as you said.
And this is especially the case on papers that used claims and EHR. Those who used Medicare SEER might have some more commonality in terms. I can't say about that because I didn't dig into them. What we did yesterday is we filtered to those that we could replicate in the data sources we currently have, which does not include SEER. Medicaid, and among those, what you said is accurately correct. Now, we could do some gymnastic and say, like, this paper is very close to that paper, and we try to say we maybe could compare them. But once you go into the depth of the paper, you can say, well, that inconsistency is because they're trying to do two different things. And then we're going to go to Tamir because his.
Yeah, my point is almost similar to Gowtham. I have a question, which is about the treatment of the two different small lung cancer and non-small cell lung cancer. So is there any difference in the treatment that can be used to, like...
Wait, is there an oncologist here, or should I?
I mean, from your research,
So
can
two things, Tamir. Yeah, two things. Like, I mean, people do that, and it might work for cases. One thing is, and so I'll talk about the treatment, and then also we have to also talk about, like, what does that mean that when you use treatment, right? But at least, like, I'm not an oncologist. I just do oncology research, and I used to do a lot of lung cancer, but this is maybe like a year and a half old. For up to 2018, so, like, everybody knows that, like, you have all these, like, immune checkpoint inhibitors that came to market, I think, around 2017, if I'm not mistaken, and then it was revolutionizing non-small cell lung cancer treatment. They have to be PD-L1 now, like, it's like all comers, whatever, right? And then you have the other targeted therapy. So for a good proportion of time, people were using it, because, like, if you're using pembrolizumab and you have lung cancer, you should be a non-small cell lung cancer patients with a PD-L1 status, because that's the label, right? That was great for a while. And then same thing with, for example, if I want to identify patients who are EGFR mutation or like T790M, I want to use osimertinib because that's it. There is nothing else, and it works, and it's a second line because there is no indication. Assumption that that's actually, like, how physicians are treating the patient, we put that aside. And then for 20-something years, small cell lung cancer, we're treating with the same thing, etoposide and whatever, like very horrible disease, and then like very, very like low life expectancy, like survival. And then same drug is shown to have some beneficial impact on a small cell lung cancer. So you see the same indications, right? So yeah, of course, there is more. The type of combinations that are used for non-small cell lung cancer are completely different. But now you have atezo and nivo and durvalumab that are being used for small cell lung cancer. So then what, right? It's a fine line. People do that. There is a 2017 or something paper that they actually say that, oh, you know what, we're going to use etoposide and a bunch of like other drugs, and say that like if people use that and like with a gymnastic of combination of radiotherapy and surgery, and then we say that these are small cell and these are non-small cell. And then time moved on. Someone came and said, oh, we have to change it because the treatments are changing. So then you have to constantly change based on treatment. That's one point. The other thing is that when you do that, you're making the assumption that everyone who's diagnosed with non-small cell lung cancer or small cell lung cancer is actually treated. In the context of lung cancer, both the up to around like, so in total around 40-something, 7% to 40% of patients are not being treated. The higher the stage of the disease or more aggressive the disease is, the higher the proportion of patients who are not getting treatment.
Really?
Yeah, there's a paper actually I have the thing. So that's a big thing, right? Well, who are we targeting? It's fine to say that I want to target patients who initiated treatment. That's totally fine. But then it's not non-small cell lung cancer. We just have to be a little bit honest with each other. And that's why, like there are some, for example, studies that have shown that there are some discrepancies if you look at like just SEER data and, for example, like a claims data, because then you see insured and uninsured, treatment initiated, not treatment initiated. And you see differences in life expectancy, overall survival. I don't know why I talked about life expectancy. So this is general ideas. Go ahead, Sam.
So what I understand, like the difference between non-small cell cancer and small cell lung cancer, from an epidemiology perspective, is 85% of lung cancer is non-small cell lung cancer, about 14% is small cell, and the rest is like insignificant things. In the non-small cell, that's where the Pacific trial and the other trials changed the standard of care in 2018. And we do have some standard of care for non-small cell lung cancer now. But we do not have a very well-prescribed standard of care for small cell lung cancer. At least that's my understanding. There are drugs there that people use, and the life expectancy of non-small cell lung cancer has improved. It can get better, but the ones for small cell lung cancer has not. And those are my high-level divisions between small cell lung cancer and non-small cell lung cancer.
Yeah, I mean, there are new drugs and new combination, and from after 2018, that was the third. Atezo was approved for small cell lung cancer. So there are changes in the treatment landscape of small cell lung cancer, but they're completely different diseases. And even very, very different survival, very different patient population. But then when you look into non-small cell lung cancer, it's an umbrella of a lot of other small diseases, right? The ALK positive KRAS plus what is it? STK11, ROS1 combination, EGFR, like the second mutation when you acquire during treatment. So then like you're gonna like, and that's the reason why, that's one of the reasons we see the mess. And I think the other difference between this and Alzheimer, for example, is that all of these are study population.
Yeah.
Right.
In terms of in the 35 articles that were identified by the community, what were the clinical ideas that they more like? How many of these are small cell lung cancer, and how many
Majority are small cell?
So it's mostly, it's all non-small cell lung cancer. So there's I think one that like tried to do something. Two. Yeah. So I don't think the problem is the distinction between the two. The problem is that there is no common idea that we can say this is what. And Gowtham, before you speak, because Chris had his hand open and then he stopped, just to make sure if Chris has wanted to share something.
Oh, sure. Thank you. Just more of a comment. I'm not an oncologist, but I feel like this issue is going to come up very frequently. Having a very heterogeneous phenotype where under which there can be like dozens of sub-phenotypes, particularly in oncology, which is like such a dynamic field, changing like every 3 to 6 months. So I'm just trying to think of like how this could work from a phenotype library perspective. Like, is the idea that we would have kind of like a parent, generalized phenotype, and then under that you would have several sub-phenotypes that would then be iterated over time? Is that, because I feel like we need to figure this out because we're going to encounter it often.
Yeah, so I think so the question that you're posing is the broader idea of the phenotype as a reusable asset, and there is multiple opinions about it, and we as a community have not completely come and agreed on one position on it. Back many years ago, we thought there's a gold standard one where you can publish one and everybody's going to use the same thing across all data sources. We have learned over time that that is the bad idea. We've also found that there's many opinions about based on what you just said. Treatments can change, paradigms can change, and how do you model that? So we have to continue to iterate and improve on it. At this stage, the purpose of the phenotype library is to be a starting place that you can pull down and then use for your study. You can modify it if you want to based on the choices of your study design, but that's just to help make sure you have a minimum quality standards to do it. And you can learn from others' work. And that's the motivation behind a library right now. So you can say, somebody did this work and they said, these are the performance characteristics in my data source. Buyer be aware, kind of thing.
So I'll just pause the question, for anybody who also have thoughts. So the problem statement we have is, it seems like non-small cell lung cancer, if we focus on that one, because it's the majority, is not the existing studies have subtypes, usually based on the treatment that they're modeling for the purpose of this study, where it leaves us with absent of a common idea as a phenotype that we can assess its consistency across literature. It's almost like it's not applicable for the exercise we are trying to do for Phenotype February. That doesn't mean, and I don't know, somebody can stress and say that's not right, because there is a common factor. In theory, everybody is trying to nest, to Chris' point, there is some global general idea here, which is non-small lung cancer, and everybody handled it in a certain way because they all required an indication. But there is an argument of no, how they handle the indication is also specific to the research question itself. So there is really no much common factor that we could assess consistency across. But instead of like talking in theory, the papers are in front of all of us. And if you look at those papers, what Anna and I tried yesterday is to find, is there a common factor that all these papers have in common in terms of phenotyping? Or is there one or two ideas that at least two studies have in common?
Yeah. How about the two small cell lung cancer? There's only two papers. Is there anything that is overlapping between them?
They're different. One is extensive stage, and let me see. So one is extensive stage, and the other one was.
Yes, I see on the abstraction column.
So one of them is extensive stage, initiated at least one line of treatment, and the other one is just looking at extensive stage and non-extensive stage.
So yeah, so small cell lung cancer, from what I remember, there is no staging there. It's either advanced or not advanced.
Yeah, extensive versus
small cell lung cancer has stage 1, stage 2, stage 3, stage 4, and sub stages within them. So stage may not be as important.
Yeah, but so the two things. The other thing is that one of them is using our beloved ICD-9 and 10, and the other is ICD-O.
Okay, is there, so, okay. Is
Two.
that because they were using data, like one was Florida Cancer Specialist and Research Institute.
Yeah. And the other is they're using US National Cancer Database.
Yeah, which is to ask you, but like there's two dimensions. It's the purpose of the study, which led to different subgroups of interest, and then there's the data source. Because you really can't talk about consistency because how you're gonna define it depends on what the data source you have. If you have just claims and EHR, or you also have a registry. Okay, let's see. Andy, Andy is I'm just going over the chat to make sure that we're covering. Yeah, Andy's exactly, that's true. Looks like if we want to focus on lung cancer, it's more of an inclusion criteria or exclusion criteria of how they try to remove things that it's not. And I think Andy, you also have an idea is, yeah, we can.
So, the
Yeah, I
idea
didn't mean
is
to
good.
distract. I just,
No,
it's a
no.
different philosophy than obviously this Phenotype February is set up for. But when you get to this kind of situation where you have only extremely granular studies that are looking at subpopulations, to move up a level, this is where I thought I went to hemonc.org and thought, well, what are they, recommending as ways to break down these patients? So that gave me categories like these driver mutations or whatever versus others, and maybe that's an approach different from Phenotype February, though I recognize it's not the plan.
Andy, what you presented is the idea. So this year's Phenotype February is to learn from the work of others by looking at literature and then seeing similarities and differences. Last year's Phenotype February, the year before, was, okay, let's come up with a clinical idea and let's model it and evaluate if it works. So going to a source like hemonc and then saying this subtype of non-small cell lung cancer, as described on hemonc's website, is the target of our phenotype development evaluation activity. That's a fair thing to do, and we've done that in the past. But that's different from the scope of today, which is what have others done? Let's see how, and this is a big learning for all of us. Right now, just a term like non-small cell lung cancer is not used in research in the sense that nobody publishes non-small cell lung cancer. They study a specific subtype, usually in the context of a treatment. That is a big insight right there.
Yeah. So so maybe that's one of the learnings, is that sometimes you can't use this method for, although they do publish the guidelines as published studies, but not as observational research.
And you can, that's a completely different things, and like you have like a process to do that, but they don't, right? So it's like in terms of like what do they want to publish? Like if I want like epidemiology of non-small cell lung cancer stage 4, they can do that, but they don't publish on that.
Alex, hands up.
Yes, thanks. Hello, everyone. My name is Alex. I'm a master's student in precision oncology and also researching a similar topic. Wanted to say a few things. So first of all, regarding this problem that we're discussing, I think this is going to be relevant for all the cancers, because cancer in general, it's kind of not a single disease, right? We can split and then we can split and split and split, and it's always like two patients will always be different. That's the one thing. And another thing, someone mentioned that the papers always go to specific subtypes. So based on my general understanding of the literature in the fields that I've been reading, is that we more or less, as a scientific community, more or less we know, for example, let's say survival curve for non-small cell lung cancer, like in general, right? So what now everyone is basically doing is like, okay, if we take one mutation, if we take one single, let's say ALK positive for this cancer type with, let's say, surgical treatment versus a chemotherapy treatment, will this be different? And this is something what is interesting from clinical perspective, it's interesting from research perspective, and that's what everyone is doing. So they're trying to find this very specific niche difference to probably push it for further like precision therapy or some clinical guidelines. Yeah, so that's the kind of motivation. Why do we see this this kind of granularity in the research?
Exactly.
That's very helpful. Yeah,
Could I just make one other observation? Sorry, just in terms of the strategy, Gowtham and Aza. You know, the notion of finding a subtype often means that you can pick relatively general population characteristics and then look for very specific treatments or something to focus it, versus trying to narrow the population because you don't have the information about the specific subtype you're looking for. And I think that's an interesting sort of output of this as to whether or not you know, based on the databases that you have, whether you approach it from focusing more on the initial population definition versus very general definition with some focusing essentially either inclusion or exclusion criteria on the population. And maybe cancer is in the kind of situation where we really should be having a pretty broad net to start with, because we're going to look at very specific indicators, genetic or, I mean, presumably treatment is based upon some kind of clinical indicators too. But do you know what I'm saying? That seems like an important thing to come away from, because they're very different strategies, as whether you start big and try to narrow, or you start narrow and then you validate sensitivity and specificity of the population.
Yeah. Alex, you'd hand this still up, or you have another, or that was an older one?
It's the old one.
Okay, no problem. Okay, so one learning that we not only people who are familiar with the field know, but now we can actually like clearly see out of our literature review, is that when it comes to lung cancer, which is probably true to our oncology, the applied research is really focused on subgroups of the disease, which is can be explained, one, because of the distinction of just lung cancer. Non-small lung cancer is a very pathological clinical description, which may be not hard to identify. In addition, it's not really relevant to the research, because the this research community want to understand things that are specific to subgroups, and so it explains that. So that's one thing. So there is no papers that are looking at just not trying to phenotype non-cell small cancer, and that's it. That's one thing. However, there is, as an idea, non-cell small cancer exists as a broader idea in an inclusion criteria, and sometimes requires some exclusion criteria that people did in a certain way in their papers. And we can maybe talk about the heterogeneity in that.
I'm so sorry, I just have to drop it out. This is a common discussion that's very, very close to my heart, but I'm so sorry I have to run, but I'll catch up with you guys, and this is amazing. Yeah. Sorry again. Bye.
No problem. Yeah, go on. Yeah. So, and maybe going to Andy's idea of like, in that case, it's really assessing the heterogeneity or consistency in those inclusion and exclusion criteria. Because there is, even if you look at this sheet and you look at the exclusion and inclusion criteria, you will see that they're generally trying to do the same thing, improving the specificity, removing potential false positives of other cancers. Yeah.
Yeah, no, I agree with you. So like, I'm looking at the spreadsheet for the first time, and what I see is there is lots of non-small cell lung cancer. All of them have different types of treatments. Some have this ALK inhibitor, some have some PD-L1, some have so on and so forth. But they all use lung cancer codes. Now, some of them have ICD-O, which is not very common, and it's specialized for like a registry type of data set, such as SEER, and is not available in general purpose data sources like this market scan and so on. But most of these data sources that are using market scan or some of those commercially available data sets use ICD-9 and ICD-10. Have you guys looked at just that
Yes.
codes and seen if they are similar or dissimilar?
Exactly. And I will, yeah. So this is where we started landing on last night after, I don't know, you guys can see my screen? Yeah. Can you see my screen? Yes. Okay. So if you see here, so one distinction you have to make is the source of data. Unlike another non-oncology phenotypes, the phenotype itself is not very specific to the data source. I mean, some are, but at the end of the day, most people have the same granularity, whether it is even when it's EHR or in very special cases, you have extra data in certain data sets. However, in oncology, the first thing that's going to decide on how you're going to phenotype is it, are you dealing with pathology histology data source, or are you dealing with just EMR and claims? So what we color coded here is if it is that yellow, those are claims or EHR data sources, which doesn't have histology pathology, which means it doesn't have those O codes because it's all related to each other, right? So if you bundle the literature into sort out the yellow ones from the fade yellow, that will give you like phenotypes that works on a registry data and phenotypes that works on claims data, claims EHR together. Okay, now if you only look at those yellows, those ones, which is going to be Medicare, mostly Medicare, Optum Scan, there's claims and EHR, then you can now focus on only ICD-10 and ICD-9s. And you can definitely then talk about, are those the same or different? And it is a good question. However, you're going to see some level of heterogeneity. And yes, we can focus on this. There's two sorts. It's not only the codes they use, but also some logic, because some papers said you have to have two codes of those. Some papers said you only have one. Some papers said it has to be inpatient. Some papers said it has to be two outpatient. So those are the common ways of phenotypes differences. But we're going to say among those, we're going to see, which is by definition, it's always going to be an inclusion criteria, because you look at the treatment and then within those, you're going to limit to the people who have those lung cancer codes in a patient in particular frequency and in particular setting. And this, yeah, that would be a fair comparison. But it will be limited, Gowtham, because the level of inconsistency is limited to those 12 codes, because there are only 12 cancer codes in the ICD-9 era, and then 18 in the ICD-10 era. And when I looked yesterday, it was mainly inconsistent. Did they include trachea? Did they not include upper respiratory, lower respiratory? And that's pretty much it. But that could be valuable. But that would be limited. That will limit our exercise, where the universe is really the heterogeneity in 9 ICD-10 codes, 18 ICD-10 codes, and then how many codes did they require, and if they require a particular setting.
I see. So if I were to summarize what you said, there are, out of the 34 studies, two of them are small cell lung cancer. That's out. And then the rest of the 32 some studies, some of them rely on data sources that have histology, pathology. Many do not. And among those that do not rely on histology, pathology, that is, they rely on generic claims and EHR data sources, even though they are studying complex clinical idea such as a subtreated group, they are using as part of their study an inclusion rule that says some lung cancer. And that lung cancer is reliant on ICD-9 and ICD-10 codes. And there's only about 18 ICD-9 codes and another 18 ICD-10 codes. And by comparing the differences and similarity just among them is something that is interesting to do.
Yeah, so it's like the 169, 162X and the 34 family, C34 family, and you're going to see how they use that.
I see. And then the questions like, is trachea part of lung cancer or not? Is bronchus part of lung cancer or not?
Yeah.
And those are choices people have made.
Yes. Yes. And then there's, again, like some other constraints that you can add. Yes. Yes. Now, I don't want to, like, this is a community work. Now, I think if you go to how they handled SEER data, where you have a whole bunch of other decisions to make depending on the O code, there you're going to see way more heterogeneity. Our limitation there is we can assess that in theory by just comparing and contrast the code selections and the other requirement selection. But because in J&J we don't have access to SEER data, we can't say anything about how that affect the characterization of patients identified, or how that affect the incidence rate, or how that affect the understanding of survival, because I can't implement this in what we have.
I think there was somebody in the community who wanted to participate in a network study, and they had access to SEER Medicare. And if they are interested in pursuing, then we could numerically quantify the impact of 20, X number of codes versus the S number of codes.
But also, I don't have knowledge. That's where oncologists can help us. I actually don't know how specific those O codes related to the stage grade. Like, could you now you have to find, do they have to have the same common disease? Like, I struggle between, because of what Asia was talking about, are we going to go into subgroups again? Well, it's those codes because they looked at advanced. It's those codes because they looked at some mutation positive, and that's only for those codes. So now we're going to tease out again what is the common factor, because I think the codes themselves are granular to these subpopulations. But maybe we need to I did not dig into that. I have no idea how much in common is this in these studies. I can tell you how much in common is between the claims and observation and like EHR, because I spent yesterday time digesting that. But yes, like somebody could dig into all these SEER studies and say, is there lung cancer codes that everybody should use when you have oncology that represent non-small cell lung cancer?
So going back to what I originally observed was, I think that what Gowtham was saying about maybe these initial ICD codes is probably we should do that, because I think that's minimum requirement for this. And then if we're looking at what actually differentiates these different patient populations and who might, from a phenotype point of view, be able to reuse something, it seems like it's to somehow categorizing these things into maybe broader buckets that we could define, like these are the histology codes that represent advanced disease. Or, as I mentioned from Hem-Onc, where they were concerned about these driver alterations, quote unquote, what is a driver alteration? If we basically just created a phenotype, a sub-phenotype essentially, which would be added to the original ICD code phenotype, which would say, these are the things that define a positive driver alteration. That could be really useful for a researcher to start from. And then you're not trying to break down individual things. You're basically grouping them, you're bucketing them. And then some of that heterogeneity just washes out because you're taking a bigger bucket. The real question is that bigger bucket of use to anybody? If it turns out they really only want this subtype ALK positive something, then what's the point of giving them a positive alteration? But clinically, it seems like that's an important bucket. Yeah. Maybe not from a research point of view.
Yeah. So I think we're coming up in a plan. Number one is the handling of the inclusion criteria for just lung cancer using ICD-10 and 9. What is that list, and how consistent it is across that, and what would be identify the consistency here and there, in addition to any other things that studies might have used as an inclusion exclusion criteria. The other one would be, I'm just rephrasing what I said. The other would be like, given all those 45 papers, is there any other buckets that actually exist that are meaningful and also clinically meaningful that we could identify? And among those, we can say this is the set of codes that are used to identify that bucket. Like I did see the term first line treatment almost everywhere, but then you're going into the treatment like world, which might be even more. But I did see like the ALK positive thing coming up a lot, or some KI. But yeah, we could see other buckets, which probably gonna be more existent in this word, in the SEER word. Where there are existing codes for stuff like that. But yeah, I think that is something we could definitely do. I mean, there are also some funny stuff when you do observational research about like even the relationship, the time relationship between, you say that this person started a treatment and you have an inclusion criteria about a lung cancer, but what is the time boundaries that you're gonna put? That is completely inconsistent. Some people say all-time prior, all-time post. Like they have the Medicare data and then they say, well, you have that treatment, and I'm gonna say as long as you have lung cancer across all your observation time in the data, I'm going to consider you in. Some people are like, you have to have that lung cancer on the same visit of that like description of that drug. So even that like manifests differently, and you're gonna have different people depending on just that implementation of the code.
That's a little surprising, though. I would think if we had a clinical oncologist here, because and maybe Alex from his research knows, but it seems like almost all of them require some sort of pathological diagnosis before they're allowed to be given the treatments. So I would hope that the diagnosis preceded the treatment.
Yeah,
Oh,
and maybe that's why they don't care, because they say, well, if somebody has that drug, then they definitely have some pathology. Whether we observe it on the data or not might be just the problem with the data missing.
Yeah, so my going in idea until Asia corrected, my thought was, if you get diagnosed with non-small cell lung cancer or some sort of a lung cancer, you're going to get treated. Otherwise, you're probably going to die. And so you're likely going to die. So treatment is a strong indicator. Like how many people, I was not expecting 35% to not receive any treatment. So my going in notion was 99% of the people who get lung cancer will get some form of a treatment. But I guess I'm wrong.
Okay, we are at time. I think I'll connect you that with Asia, but I think what we reach is that we will focus on the inclusion criteria of lung cancer in those different papers that look at different subtypes of lung cancer and how these papers handle them, at least in the worlds of claims and EHR data, where you have to have those ICD codes. And we'll focus on what the codes are and how they were implemented within what constraints and what logic. And we will summarize that and replicate that and see how that affects the type of lung cancer patients you're catching up in our data sources. I saw a comment in the, did I miss?
No, they were just.
Okay, yeah.
This is tough. You guys, you probably didn't expect it to be quite so tough when it was chosen, but.
Well, oncology people always say there's no point of having a phenotype in a library for oncology. So it was us challenging that notion.
We will prove them wrong.
We'll prove that,
Right.
you still have like components you're gonna use no matter what, right? Okay, thank you everybody. It is 10 o'clock and we'll follow up. Thank you everyone. Bye-bye.